My name is Wiltrud. I'm a critical care physician from the Charité University here in Berlin, in Germany. I want to extend a warm welcome to all of you who have joined today for the kickoff of our global sepsis lecture, which is brought to you by the Sub-Saharan Africa Consortium for the Advancement of Innovative Research and Care in Sepsis, short STARES. This warm welcome of mine also comes in the name of our partners in Africa. We have 7 countries, 8 partners in 7 countries, in the countries of Uganda, Ethiopia, Ghana, DRC, Mozambique, Sierra Leone, and Nigeria, who are part of the STARES network, which is graciously funded by the German Federal Ministry of Education and Research. With specific regards to the Global Sepsis Lecture Series that we're kicking off today, I also very much want to thank the African Federation of Emergency Medicine. AFEM has been a collaborator and strong supporter from the very start of this undertaking. And I think Dr. Joe Bonney, who is the president of AFEM, will also be speak a few words later on. We are also very much looking forward to, over the course of this series, to deepen our already existing collaboration with the African Sepsis Alliance, as STARES, and to maybe focus together a little bit on sustaining and scaling up this very global sepsis lecture series that we're starting today. To put a few people to the logos that we've just seen, please meet the STARES Consortium on the bottom right of the slide, and our director, Dr. Nathan Kenya Mugisha, at the top right of this slide. As I said, it's 8 institutions in 7 countries, apart from the partners in Germany, of course, in Düsseldorf and Germany. And all of us, we work together in STARES. And what do we do? STARES is a research network, first and foremost, maybe. There is 5 research studies, including 2 randomized controlled trials, and all of this research is nested along the patient pathway. So we take a patient-centered approach and look at the patient pathway from the community where sepsis most of the time starts to the hospital and back after discharge in the community. We look at epidemiology, we look at diagnostics, and we look at quality improvement in our research. We also, as a network, have a strong focus on networking and policy engagement. And at the bottom of the slide, you can see 2 impressions of how the network is attempting to do that. One of those pictures taken when the PIs of STARES met with representatives of the Africa CDC almost 1.5 years ago in Ethiopia. And one of the pictures from a training in evidence informed decision making that all of the partners are undergoing at the moment. Another very big focus of STARES, though, is in capacity strengthening. And we do this on several levels. There's institutional capacity strengthening, there's strengthening of research capacity, because that's what STARES is trying to deliver. But there's also, and really not least, clinical capacity building. We're trying to strengthen the clinical workforce and provide training on everything sepsis, and we're also trying to establish telemedical structures in 2 pilot countries in the network to support that. Why are we doing all this? There are 13.7 million deaths due to sepsis every year globally. 10% of these deaths are actually directly attributable to antimicrobial resistance, which highlights an overlap between the 2 topics, sepsis and AMR, and the need to address them both synergistically. To put it in the words of the CEO of the Global Sepsis Alliance, Dr. Mariam Jashi, sepsis is the face of AMR, but sepsis is so much more. As I said, there are 13.7 million deaths, and there's a huge global disparity in sepsis deaths across the globe. 4 million of these deaths, 4 million children, women, and men die due to sepsis in sub-Saharan Africa alone each year. And according to WHO, most of these deaths are preventable. And they are preventable with improved prevention, with vaccines, with early detection, and adequate evidence-based treatment of the disease. And now, to focus in on what we're doing today, clinical frontline staff, nurses, physicians, midwives, all other professions, and I again explicitly welcome everyone from every profession here that works in health. Clinical frontline staff is at the center of improving prevention, early recognition, and evidence-based treatment of sepsis in the hospital. And that's what we are. That's why we're here today. STAIRS has made it a part of its mission to strengthen capacity amongst clinical teams. And the Global Sepsis Lecture Series is exactly that. Our objectives are to improve awareness amongst clinical teams for sepsis as a medical emergency, as well as for the consequences of sepsis that patients suffer who survive. We want to facilitate capacity strengthening on everything sepsis. As I said, there are important overlaps with other topics like antimicrobial resistance, but also infection prevention and control. We want to provide a platform for knowledge exchange with international experts from Africa and other countries. We want to point at research gaps in resource-limited settings, and specifically in resource-limited settings, because there's where the need is biggest for creating high-quality evidence. And we want to do that from a patient-centered perspective. We want to look at quality improvement and other solutions to the challenge of implementing clinical guidelines. And we want to create an interprofessional exchange on what is relevant to frontline clinical staff in Africa. And in order to do that, the Global Sepsis Lecture Series will run for the next 24 months, every other week on Tuesdays, at this very time that we're meeting today. We're starting today with our introductory session. And once I have finished my little presentation, we will listen to our experts that are here today. And I am very happy to present you here the flyer or the program for the first part of the Global Sepsis Lecture Series, which consists of 6 sessions until June 17. The Global Sepsis Lecture Series wants to bring this to you. As I said, it's going to be bi-weekly sessions over the coming 24 months with experts from Africa and all over the world. We want to have dedicated time in our sessions for audience question and answers at the end of each session. We want a platform for capacity strengthening and knowledge exchange on everything sepsis. We're going to record our sessions and going to make them available from our website, stairsepsis.com, and also from other open access sources on the web. And we are also, and this is coming soon, and we will be providing information about this to you after the session. We are also going to obtain or look at options to obtain CME points or continued professional development points in the respective countries for this series. What we hope for to get from you is active participation. We want to encourage discussion. We want feedback. We very much encourage you to use the chat already today. Please put your questions in the chat. My colleague Elaine is there to look at it and maybe later on post some of the questions that you put in the chat to the audience. Obviously, you can also just speak up. We are hoping for participants from all the frontline professions. We're hoping for a growing audience as the series progresses over the next 2 years. So please share the word and share the registration link in the info. And yes, questions. As I said before, please feel free to use the chat. Before we dive into the panel, let me just quickly point you to some further resources on the web. There's the STAIRS website, stairsepsis.com. I've mentioned this. There's the AFEM website, afem.africa. There's the website of the African Sepsis Alliance, africansepsisalliance.org. We very much want you, as you might have seen on the program for the part 1 of our series, we are not going to have a session on April 8, because on that very date, the World Sepsis Congress, brought to you by the Global Sepsis Alliance, is taking place. And we very much invite you to register for that one now. It's free, it's online. This is the URL where you can do that. There's scientific literature on sepsis to find under Sepsis Science, and also the World Health Organization has information pages on sepsis for everyone who's interested. Please, whenever you have a question outside of the sessions, please get in touch with us. There's an email address at the bottom of this slide. There's our website and a QR code to access it. And coming soon, we will be opening a STAIRS Global Sepsis Lecture WhatsApp group. I'm going to stop talking now and going to hopefully one by one, and I hope that all of them were able to make it today. I'm going to give the word to our experts from our network and beyond that are here today to open this Global Sepsis Lecture Series together with me. So let me see. Dr. Kenya, are you here? Are you with us today? Dr. Kenya is the director of the STAIRS Network, our most senior member. And I would very much like to know if he's here today. I don't know. If not, then I'm just going to start with a little question to Shevin. Dr. Shevin Jacob is the Chief Scientific Officer of our network. Shevin Jacob is also a reader for sepsis research at the Liverpool School of Tropical Medicine. Shevin, are you here?
I am here.
We didn't lose you. Okay, that's good.
You're welcome.
Shevin, please, this is a very open sort of panel session. I would just like you to maybe say a few words about STAIRS in addition to the slides that I've just shown. And maybe what do you think? Why is it important for clinical teams? Why is this kind of capacity strengthening relevant and necessary, especially in the sub-Saharan African context? Please, over to you.
Ian again. See you next time.
Hi, Francisco. Do you think you can mute? Put yourself on mute.
Okay. Okay. So, sorry.
No problem.
No worries. Okay.
Yeah. So thanks for that question, Wiltrude, and thank you for the introduction to STAIRS. I think all of us are extremely excited to be a part of this and to kind of expand the research and capacity as you've described it through STAIRS. As we continue to try and think about what are the sort of the solutions that can be tailored in Africa across many different types of settings, different types of or different countries, whether they're in public or private, whether it's rural or urban. The context that's provided across this large continent. The solutions to caring for patients with sepsis are so there are so many, and yet not very systematically tapped into. We don't have the research structures in place in a systematic way to be able to identify kind of the epidemiology and really in those 4 million people who are dying from sepsis each year in sub-Saharan Africa. What exactly are they dying from? What are the risk factors for their deaths? What were the additional factors that contributed to that mortality? What is the longer term morbidity? What are the social constructs and the social consequences of sepsis? The overall costs. and that's on the consequence side. And then on the opportunity side, where are the opportunities for establishing sort of context and settings based solutions, whether it's in terms of the research that's generated from this area, whether it's in advancing to treatments and diagnostics that are manufactured and distributed in across Africa, and just the lessons that we can learn across our multiple settings and contexts that would be sort of so invaluable for a network like this one. And then, even globally, so that sort of south, north, or however you want to talk about it, but from this region to other parts of the world, the lessons that can be learned with all the experience that is here. So I just want to say, all of that just to say that, through STAIRS, we have an opportunity to expand on research that is being done, and that's just the first start. You can see on this call, there's already 85 participants on day one of this incredible, sort of kickoff of a lecture series. And we hope that just continues to grow and grow so that we can learn from each other and really, start to define what those solutions are to the very problems that each of you are facing, at the bedside for the patients that you're caring for on a day-to-day basis. So that'll be my first foray into this, and I look forward to hearing more from my other colleagues too.
Thanks, Shevin. Thank you very much. You remind me of. Sorry if I'm going to continue in a second, but you remind me very much of the moment that I learned that we do have clinical guidelines for sepsis treatment. There's Surviving Sepsis Campaign guidelines, but actually those guidelines are not really applicable, or they are not sufficient maybe for the context that we're talking about today, because none of the evidence that they are based on, or hardly any of the evidence that they are based on, actually comes from low and middle income settings. And I'm very glad that STAIRS is going to address that issue. Dr. Joe Bonney. Joe, are you here? Can you hear me? Dr. Joe Bonney is the president of the African Federation for Emergency Medicine. And as I said before, I'm very, very grateful that he's supporting these efforts. Dr. Joe Bonney is also a clinician, emergency care specialist in Kumasi, in Ghana. Joe, why is sepsis important in emergency medicine?
So in my region, and I can speak specifically for clinical work that we've seen in Ghana, we have a lot of patients that come in at various points in the pathway of care. Aside the regular delays that they will come through, this is extra compounded by the unorthodox herbal treatments that people will be using along the way, the strong affinity for religious healing, and before they end up in the hospital. This just provides extra layers of either delay or inappropriate care, and people usually will present at the point where they are, and it becomes an emergency and are seen in very acute states. The idea of promoting the sepsis training and sepsis recognition on all these fronts would allow this to be picked up at the smallest level hospitals, at the CHIPS compounds, for physician assistants and doctors who don't have advanced training to be able to suspect an infection and start treatment, understand where the limitations are, and know which patients that can be managed at which level, or which patients needs to move to a secondary level for care. And I think this is paramount in all cases. But in sepsis, the benefits you can see when you start putting interventions are much profound and drastically can reduce the morbidity, mortality, and long-term effect of the sepsis case in a lot of people. This is why, as myself, I'm very proud to be associated with this, but also AFEM really flies high the banner of being able to put in interventions that will help curb the sepsis effects across the African continent. We're glad, and I'm quite amazed with the attendance here. But I am sure with this 85 ambassadors going out to say how great they think today's session was, we definitely should have more capacity for the next time, as we know we will continue to grow and build this. I'm very happy to have everyone here. And we're also very happy to get feedback on what you think we can do as a network, whether you are part of AFEM or part of any emergency medicine group, which is remotely even linked to AFEM. Please reach out. Let us know how we can make this better and how this can be responsive to you at the patient's bedside. Thank you.
Thank you, Joe. Thank you so much. I'm very glad to have you on board with this and AFEM too. And I'm sure that we're going to continue to grow. As I said, it's like an explicit target of the series to have like an ever-growing audience. And please, everyone who is here today, please share across clinical teams and to other countries in Africa the info about this series. Dr. John, are you here? Dr. John Adabi Appiah is a senior specialist in Kumasi, Ghana as well. John is a pediatrician and the head of the pediatric ICU at the Komfo-Anokye Teaching Hospital in Kumasi. John has like a decades-long experience in pediatric critical care, and I think is the best person to maybe say a few words about pediatric sepsis and about the challenges that clinicians are facing in pediatric sepsis, whether it's about recognition or quality improvement in clinical care or other limitations in clinical care that you are facing. John, are you here?
Yeah, Uthru, I'm here. Thanks for the generous introduction. As a pediatrician working in resource limited setting, low middle income country, I share a lot of frustrations and a lot of challenges managing cases across board. From recognition to patient discharge, post-discharge follow-up in terms of sepsis. There is a huge gap. We all know the burden, which you have brilliantly, and then Shervin and other colleagues have outlined that we have a high burden of the disease with us in the continent. The newborns, for instance, sit on top of this burden, and also mortality is very high in the newborn period. My experience spanning through these years is the fact that outside the newborn period and beyond that, most places in Africa, we don't even count other age groups with sepsis. So you talk about maternal sepsis, you talk about neonatal sepsis. We barely have records of what actually is happening to most of the patients in between. And that is very frustrating because it doesn't really give the true picture. What we have been working with is actually projected data and information that we have been working with. And with that, having said that, we look at the continent itself, describing or understanding how sepsis present in pediatric patients outside the recognition in terms of recognizing the disease in these age groups becomes a huge burden. How do you teach someone? How do you draw someone's attention that this is sepsis? Well, sepsis, it's becoming very difficult to explain to anyone to be able to identify what sepsis is. Beyond that, once you get to the point where you are suspecting sepsis, how do we diagnose sepsis? It's also a huge problem that we've not been able to address. Malaria, we are able to pick up malaria, uncomplicated malaria, with basic diagnostic tests, and that should quickly give you a guide as to what to do for the patient. What about sepsis? Move on to talk about treatment of sepsis, the opportunities. Sepsis is an infectious disease. Sepsis sits in the critical care unit. And when you say the critical care unit across Africa, what do we mean by the critical care unit? Are we talking about the four corners of the world, the ward in a specific place? I don't think that's what we are looking at. We look beyond the intensive care, what we typically call the intensive care unit, what we typically call our emergency units, where we have four corners of the world. Most cases are managed outside these spaces. And how do we guide those managing healthcare workers on how to manage patients who are critically ill in a setting where resources are not available? What supportive care is available? We know with advanced sepsis, these are huge challenges that we are facing. The recent publication by the African Critical Care Group, follow-up to what they published during COVID era, described the situation clearly on the continent. In addition, parity, which also looked at point needs of critical illness as a combination with sepsis. Sepsis is a prototype. Sepsis as a prototype for critical illness shows a picture of what actually is happening across low and low middle income countries and resource limited settings. Now, looking at outside, we talk about antibiotics, we talk about resuscitation, we talk about fluids. Years back indicate that fluids in African child with fever, this is a whole challenge. We don't understand what fluid does to the patient. We know that patients who receive, febrile children who receive fluids as part of their management, outcomes are poorer. Where do we go? Where do we turn to? What do we do? Sepsis is associated with shock. Sepsis is associated with severe disease. Our main approach, one of them is to resuscitate. How do we go about it? These pose questions that we need answers to. And lastly, you've hit on antibiotics, but I also want to talk about post-discharge patients who are discharged beyond after treatment. Significant number of them do not make it. More than a quarter of them actually die within the first 30 days of life. Within 90 days, a significant proportion of them will die. What are we doing to answer these questions? And this is where I guess for the pediatric population, where we bear the brunt of the disease, the burden, we need to pay attention to, and I'm sure most pediatricians will attest to this. And I guess one of the, what we need to do is to be able to provide answers. And STES actually is trying to provide some basic answers to some of these, which will help clinicians to be able to work with that. And lastly, I want to touch about the fact that we are looking at how we can innovatively care for patients with sepsis. And part of the work of STES is to provide innovative care. Is it business as usual? What can we do differently to spread, to innovatively care for patients we manage across all different settings? I guess I've asked more questions than answers for now. And I guess this is what the next 24 months we hope to be able to address. Thank you.
John, thank you so, so much. I think you have very nicely and brilliantly asked all the relevant questions. You've talked about capacity that needs to be built outside the critical care units. You talked about the difficulty of sepsis recognition, about all the different clinical topics that are relevant in sepsis management, fluid management, shock, the recognition of shock, the shock reversal. We talked about antibiotics, but also about the post-discharge management of patients who actually survived sepsis, be it adult or pediatric patients. This is exactly the scope of the global sepsis lecture series. We will be having talks about each and every of these specific topics. And again, like Joe has stressed it too, please give us your feedback. If you have suggestions for topics, if you have specific questions that you want answered with regards to a specific part of sepsis management, please let us know. We do have a plan going forward for speakers and for topics. And you've seen the first 6 topics, which will also touch on pediatric sepsis and the recognition of pediatric sepsis. It will also include a look at sepsis as a medical emergency and the early recognition and first response necessities basically for clinical management. But there's so much more, and John has just very nicely gave us the rundown on that one. Thank you so much. I do think that we do have Tafese here too. Is that right? Tafese, are you around? Yes, thank you. Dr. Tafese Tufa is a clinical microbiologist in Asella in Ethiopia, and the country PI of the STAIRS network in Ethiopia, and also our Deputy Chief Scientific Officer. Tafese, thank you so much for joining. You've seen that I touched a little bit about the overlaps between AMR and sepsis as an example of topics that need to be addressed when we talk about sepsis. As I said, we want to talk about everything sepsis, including IPC and AMR. What's your take? Where do you think is the biggest challenge? Where do you think we need the most capacity building? And what would be your favorite focus for the Global Sepsis Lecture Series?
Yeah, thank you, Betrud. When we talk about sepsis, it is obvious, just remembering about the cause of sepsis pathogens. Is it bacteria? Is it fungi, or is it virus or parasite? That is the most important. In most of cases, we even may not know that. And if we really know the pathogens, now we can talk about antimicrobial resistance. So pathogens and the resistance pattern is very important to manage sepsis accordingly. For example, in most of cases, we use blood culture to diagnose sepsis, but we know that blood culture not cover all pathogens. Likely it cover 70 or 60% of the pathogens, even if which is not available in most of the sites. So we have to consider molecular diagnosis also as option, at least to get the epidemiological data for clinicians for empirical initiation. If we initiate antibiotic which is wrong or which is not effective, still we are expanding antimicrobial resistance strains, because the drug we use, if it's wrong, not treat the patient, rather not help us to cure or manage the patient, rather it expand resistance strains because we are full of bacteria. That means when we should know at least epidemiological data for antibiotic initiation. I remember in Asala we did a study and we found the ACT and also antibiotic initiated empirically when we compare more than 70% antibiotic initiated was ineffective. It is not effective. When we compare with the local data, we produced later after 2 days or 3 days. For this reason, now just most of the patients who develop sepsis, they may develop sepsis with highly drug-resistant bacteria, MDR bacteria. So if it's true, when we initiate antibiotic empirically, it is unlikely to help the patient. So we have to improve our diagnostic facility to initiate as early as possible right antibiotics. Unless otherwise, it is difficult. And for others, non-culturable pathogens, we should also consider molecular diagnosis and the rapid test. For example, like rickettsia, malaria, they may also undermine. And most important, invasive fungal infection, also in ICU patient or in sepsis patient, may be common. So for this also, no need to initiate antibiotic. Rather, we have to start appropriate antifungal. To plan for this, clinicians need evidence, the data, good standardized microbiology result. Unless otherwise, it is difficult. So in general, when we talk about sepsis, talking about antibiotic stewardship is very important, and the awareness creation is very important. Compliance of clinicians to use microbiology lab also very important. Yeah, this is all what I can say, Ruth.
Thank you, Tafes. Thank you so much. You've reminded us of some very important points. For example, that sepsis can also have viral causes or be caused by fungi and not necessarily only and all the time by bacteria. I think I think you all remember the slide in the beginning where it became visible that 10% of sepsis deaths are actually directly attributable to antimicrobial resistance, so multi-resistant pathogens. And, you know, given the projections of how AMR is just going to be a bigger problem in the coming decades, I think that also sepsis is going to be an even bigger problem too, because part of it, if not the majority, but part of it is actually caused by multi-resistant bacteria as well. So we will also be focusing on aspects of antibiotic stewardship in clinical management of sepsis. And I'm very much looking forward to that one too. I just saw a question pop up in the chat. How often is this repeated? We will be having sessions every other week, so one big session in 2 weeks across like 24 months. So that's the interval that's scheduled at the moment, and each of the sessions will have a specific topic. We will be sending information on the specific topic of the respective session in advance. We will send reminders. All the sessions will be on Tuesday. I see a hand raised. Please, Mohamed El Fatih, can I please?
Yes, hi everyone. Thanks for the elegant introduction. My name is Mohamed El Fatih, internal medicine physician and vice president of Sudanese Sepsis Alliance. I'm truly grateful to be here today, and it's my first time to attending this event, and I appreciate the warm invitation. As you all know, our country is facing extremely challenging times, but we remain resilient and committed to ensuring that education is continuous despite the war. And I believe through STAIRS we can make difference, and we are ready to engage in any way possible. And thank you once again for this opportunity. If you allow me, if possible, to take into account the precision medicine in sepsis, the phenotype and the endotype. And here I mean by the phenotype, the clinical classification. I mean the hyperinflammation, angioimmune dysregulation, and coagulopathy. And by the endotype, I mean the molecular part.
Mhm.
How we deal with the hyperinflammation and how we deal with the hyperinflammation and the coagulopathy happening from sepsis. So as you mentioned earlier, the patient-centered care. So what I look for is to tailor the intervention based on the endotype of the patients. So that it will help us to precisely manage patients based on individual basis. As you know that they are look-alike in the feature of the clinical sepsis, but they are different in the response for the management. So this one topic I suggest. The other topic is systems thinking. As you know, that sepsis is not just affecting our patients, even sepsis affecting our system. So if we are not taking account how to approach the sepsis holistically through the system thinking, we will be trapped on the system. And thank you once again.
Thank you, Dr. Mohamed El-Fathi. Would you mind if I sent you a speaker invitation after this?
Yes, for sure.
Okay, I will send you one. I'm very happy to have you here. Thanks for joining us for this very first session. Okay, are there other questions, Elaine? Did we get some more questions? I don't see if. Let me just quickly go between the pages. There's so many of you. I don't see any more raised hands. Do we have anything else in the chat?
Yeah, so we have one question, which is, what is the view of the experts on the experiences of nurse on sepsis care?
Oh, wow, that's a good one. I am, as you can see, I almost feel bad that there's no nurse expert on the panel, but I am not sure if maybe, just maybe, Emmanuel has made it here. Joe, do you see? Actually, Emmanuel is the nurse lead of AFAM. And an emergency care nurse, also in Kumasi in Ghana. And as you might have seen, I'll just pull up the flyer again in a minute. Emmanuel is actually going to talk on May 6th, not on May 6th, I'm sorry, let me correct myself, on May 20, about quality improvement for sepsis care in resource-limited settings. And I'm very happy to say that that's not going to be his only talk. We will be having a session that's called recognition of sepsis from a nurse perspective in August. And we will be joined for this one, not joined, but she's going to be the speaker together with Emmanuel on early recognition from a nurse perspective by Kathleen Ballman, who is the president of the World Federation of Critical Care Nurses. I hope I got all the dates right now, but let's see. As I said, you will be getting information about speakers and specific topics beforehand, and then reminders too. So no, we're not planning to because sepsis is a team sport, and I'm a clinician myself. I work on an ICU, and there would be no working without the team. So I see Halima, you're raising your hand. Is this a direct comment maybe to the topic, please?
Yes, thank you so much. I'm happy to be here. I kind of joined late, but I got here when you were asking about a nurse being on the panel. Well, I don't know if there's any nurse on the panel, but I am a nurse.
Yes, please join the panel then.
So I would love to talk about the nursing perspective.
Yes.
When we talk about sepsis or AMR or any of these issues. Thank you.
Thanks, Halima. I'm very glad to see that there's people coming in, and there's, we've sent out speaker invitations, but there's always, a need for more speakers. And the nurse perspective, I think, is an essential one, as sepsis care is so many times in so many settings driven by nurses, actually, and early recognition is done by the people that are closest to the patients, and I feel like that's an essential part. Thanks for that point. I think this is really essential. There is the social sciences are definitely also a perspective that is like extremely valuable. As I said, the STAIRS research is taking a patient-centered perspective, and I do believe that we as clinicians, we do have to get better at looking at our patient and understanding patient pathways, if we want to treat them right. And I do also think that there's a lot of lessons to learn in looking at the patient pathway. I know that some scientists who are also part of STAIRS these days have already started to do that in different countries that are also part of this network. And I really hope that we will see more of that too. STAIRS is also, as Shevin pointed out earlier, looking at epidemiology and the trying to characterize deaths in the community and understand how sepsis develops. It's a hugely important aspect of when you look at sepsis. We do have a little bit more of a focus on clinical management, but I'm very happy for the social science perspective on all of the aspects, on all of those aspects too.
And then we have two questions regarding the recording of the lectures, if they are recorded, and if it can be sent to the emails of the participants.
Okay. First, yes, it will be recorded. We will be recording all of the sessions, unless a speaker says no. But that's part of the deal, that a speaker who presents is happy to have his session and his presentation recorded and uploaded online. We will be sharing those sessions at least at the very minimum on the STAIRS website. This will not happen tomorrow. It will probably take a few weeks for us to do that. So apologies in advance, but you will have them all as they come, as we record new sessions, they will be uploaded. I mentioned earlier that we are happy to work together with the African Sepsis Alliance, and we're also working with the African Federation of Emergency Medicine. And together, I'm sure we will find the best ways to make things and recordings available to everyone. So if you ever miss one of the sessions, it's not the end of the world. There will be recordings to watch afterwards. Okay.
No further questions.
No further questions from the chat. So I'm going back to our panel. Shevin, John, Joe, is there anything, Tafesi, is there anything, Halima, is there anything that you want to add or that you want to say in terms of closing words going forward? Anything I absolutely didn't say? Please go ahead.
I'll just reiterate. Please, think about topics that are affecting your daily practice and the patients that you care for on a daily basis. And let us know. What do you want to hear more about? We're here to learn from each other and to kind of improve on what we can do for sepsis in the hospitals in front of us. So please brainstorm, and next time bring a friend. This group is awesome already, and let's continue to grow it. Thank you.
Maybe John.
Let me add that we are also have seen quite a number of colleagues with a lot of experience in sepsis who are not part of STES. And I guess we are going to reach out to some of you to contribute to the next 24 months of activities that we are going to do. We need to learn from everybody. We need to gain from everybody. But the other aspect which I guess we need to look at is also look at what at the national level are we going to do to be able to spread sepsis. I don't know how many countries in Africa have a national sepsis policy, sepsis roadmap. All these are key and important aspects that we need to consider. And we look at developing something in this path to address the basic issue. If it's taken up at the national level, the rest of the work will be less easier. Thank you.
Thanks, John. That's a hugely important point. National sepsis plans, national sepsis activities are badly needed. And this, if you have any questions as to start that kind of movement in your country, please also don't hesitate to reach out. STAIRS is probably the right place to direct those questions to. Halima, you have your hand up. Please go ahead.
Yes, thank you. And thank you, Shervin and John. Nice to know that you are inviting more experts on this panel, on this participation list, because I mean, I'm sure there are many experts in sepsis who are here. I just want to also reiterate what you said, John, about having national action plans in African countries. That has been one of the biggest challenge that I've faced, and I've been trying to get to the national body with this, I mean, the federal government with this. Unfortunately, it has not happened. Somehow, it's quite difficult when you're working without resources. Resources in the sense of, I mean, funding. When you are taking, a project somewhere, they will expect that you have grants or you have some money somewhere that is, supporting this project. So, but in sepsis, it's not, that way. So it's so difficult, moving things forward. Here I have my team who are, working on, doing some research on sepsis in children. And we are about to, come up with our findings, just analyzing the data. So I'm sure this is going to help us, when we have some write-up. So we have data that we can back up, whatever we have, to the government. So I think it would be good if you include funding or how to get resources onto sepsis project. I mean, it's very important. Thank you.
Thank you, Halima. Thank you. This is thanks for that point. Joe, I see your hand up. Maybe if it's okay for everyone else, I'll give the closing words to Joe, if that's all right.
It's quite interesting because that is what my closing word was going to be. That if we're able to keep this consistent for 24 months, 1 hour every other week, I think it's going to be one of the most impactful effects that we have done in sepsis control. And I would really appreciate all the people that have been able to make it for this first run. We will increase capacity. We will be able to share these videos quickly. As we continue to grow, we will be able to get CPD points across board. So please tell your friends, make this a Tuesday movement that we will have so many people joining and learning and putting up their hands to be experts and faculty to be able to teach on these moving forward. So thank you so much, and we'll throw it back to you. And thanks the team for being able to put all of this together.
Thanks, Joe. A little bit of a closing words ping pong, but yes, there's nothing to add to what Joe has said. I do believe I'm overwhelmed by the turnout today already. This is the first session. I would have never thought it would be so many people. Let's keep this up. As I have said, the next session is going to be on April 22. We will be using the emails that you all have used for registering to send out the information to all of you. We're going to be sending reminders, and I'm very, very happy, looking forward, and yeah, to continue this with all of you, and see you in the next session. And please, again, it cannot be stressed enough, send us your feedback. Let us know what your favorite topics will be. Give us some input. And if you want to be a speaker, also let us know. Thank you so much for today. Have a very good rest of the day, very good evening, wherever you are, and see you soon.